Boris Atabe, who will be speaking to us about the comorbidities and risk of head and neck cancer in the French West Indies. French West Indies that would have been spoken about a lot from Dr. King's keynote presentation this morning. So while Boris finds his way, I'm going to read his bio. Oops, where is it? Okay, there we go. Right. So Boris Atabe is a Master's of Public Health student at McGill University, originally from Cameroon. Throughout his academic journey, he has developed a strong interest for infectious and tropical diseases, alongside a growing focus on global cancer epidemiology, particularly in marginalized and under-researched populations. These interests led him to pursue a practicum under the supervision of Dr. Yves Auguste, myself, where he investigated the association between personal medical history and head and neck cancer in the French West Indies. By exploring these relationships within the Afro Caribbean context, his work highlights how our lifestyle and environmental factors shape disease patterns and contribute to future cancer prevention and research efforts in the Caribbean. So, Boris, the floor is yours.
Hi, hello everyone. I hope you can see my screen. So, as mentioned, my name is Boris, and I want to begin by saying thank you for the opportunity to present my work here today. The project I'll be talking about, it's a project that I worked on during my 16-week summer practicum that was supervised by Dr. Gis, as he mentioned, during which we focused on exploring how personal medical history, so by personal medical history, I mean conditions that individuals live with on a day-to-day basis, such as like asthma, diabetes, chronic bronchitis, just to name a few, and basically how these conditions influence the risk of head and neck cancer in the French West Indies, specifically in Guadeloupe and Martinique. And so, to begin with a little background and rationale, head and neck cancer is one of six most common cancers worldwide, with over 700,000 new cases and over 300,000 deaths each year. In the French West Indies, the age standardized incidence rate are estimated at 8.1 cases per 100,000 population in Guadeloupe and 5.7 cases per 100,000 population in Martinique. Now, despite this burden, most of the existing evidence on the risk factors on head and neck cancer come from North American and European studies, leaving Afro-Caribbean populations largely understudied. Now, biologically, head and neck cancer is influenced by genetic and metabolic changes, as well as chronic inflammation and immune dysfunction. And all of the conditions that we looked at in this study are linked to inflammation and or immune dysfunction in one way or another, but their actual role in head and neck cancer remains unclear and inconclusive. This is what brought us to the objective of this study, which was to help fill this knowledge gap by investigating whether certain personal medical conditions are associated with head and neck cancer risk in these populations. Now, for the methods, this was a secondary analysis, and we used data from the ECAP and C case study. This was a population-based study that was conducted between 2013 and 2016 and included 130 cases of newly diagnosed head and neck squamous cell carcinoma, so head and neck cancer, and 405 controls that were randomly selected from the general population of Martinique and Guadeloupe. And these controls were frequently matched by age and sex. Now, the data were collected through face-to-face interviews using structured questionnaires, and the questionnaires covered things like social demographics, participant medical history, tobacco and alcohol use, HPV status, among other factors. Um, we looked at 11 chronic inflammatory or infectious or immune-related conditions. I would just name a few, such as asthma, esophageal reflux, or GERD, oral herpes simplex virus, chronic bronchitis, and in order for any of these exposures or any of these diseases to be classified as an exposure, they were supposed to have been diagnosed at least 2 years prior to recruitment into the study. And then for analysis, we then used the multivariate logistic regression to estimate the odds ratio for each condition, controlling for major confounders such as age, sex, BMI, tobacco and alcohol use, HPV status, recruitment site, and education level. Now, moving on quickly to the results, I'm going to start with some baseline characteristics from our sample. So most of the head and neck cancer cases were men with an average age of 60, and most of our controls were also men with an average age of 57. Um, Head and neck cancer cases also reported lower education level as well as higher smoking and alcohol use compared to the controls. Next, we looked at the prevalence of these diseases among the cases and the controls in this population. And among the conditions we look at, you can see that certain diseases appear to be more prevalent among the participants, most especially gastroesophageal reflux, so GERD, and then closely followed by diabetes and asthma, as well as rhinitis and sinusitis. Now, moving on to our main findings for our study. In our adjusted models where we controlled for confounders, so all the confounders I mentioned earlier, certain conditions we found were inversely associated with head and neck cancer risk. So, for example, I've mentioned here, you could see asthma, you can see GERD, you can see HSV, chronic bronchitis, and all of these where, as I mentioned, were inversely associated with head and neck cancer. Meanwhile, several other conditions were not significantly associated with head and neck cancer risk after these adjustments. Now, as you can see in this, what I'm trying to show in this forest, adjusted forest plot right here is basically the association I'm talking about between personal medical history and head and neck cancer. And you can see, as I was mentioning, you have some of these diseases that we found some inverse association, but then for most of the other diseases, this association was not significant in any way as to super large confidence intervals and um, yeah, and as point estimates going past our mean of one. Um, so I think now this study is not without its limitations, obviously. First, as a retrospective case control study, there's potential for recall bias in terms of reporting comorbidities. And then there's also residual confounding from unmeasured behavior and environmental exposures that we could not completely rule out. But overall, I would say this study represents one of the first efforts made to explore these associations within an Afro-Caribbean population. With the observations that we made, could see that the study offers valuable insight into um, the complex and understudied relationship between comorbidity patterns and head and neck cancer risk in Afro-Caribbean populations. Also, our findings underscore the importance of considering how community management and regional disease patterns may influence cancer epidemiologies in ways that differ from from those that have been documented in predominantly white populations. And lastly, our results should be viewed as indicative of several important paths for future research, including large-scale studies with cross-regional comparisons within the Caribbean and other Black populations. Thank you very much.
Right. So, thank you. Thank you, Boris. So, I mean, I was part of this work, so I don't have many comments to say. I will go ahead and open the floor to questions, and if there's none immediately, I'll go ahead and make a few commentaries on this. Okay, so whilst let me just see if we're good on time. Okay, so we have time for at least two questions. So I'll go ahead and make just a small commentary on this. We made a lot of comments about the French West Indies this morning and how they could be a beacon for capacity building and strengthening in our region. I want to highlight that these kinds of studies, the one that Boris just presented, are extremely difficult to put in place. An epidemiological study of this magnitude is not doesn't come to fruition overnight, and it requires significant infrastructure in terms of case ascertainment and also the methods to include persons from the general population. So, I mean, what I'm trying to say here is that what Boris just presented is for us in the Caribbean, and I imagine so much so also in the South Pacific and other parts of the world in Atlantic. This is a type of study that we all want to aspire to. And it shows that having the resources can really bring us very far in what we want to do. And this case control studies represents one of the few in the Caribbean that have this magnitude and this level of quality to produce these results. I'm not saying this because it's the study that I went for, I did for my PhD, but it is true. I've been working on this for a while and I haven't seen anyone else in any other island complete a study of this magnitude, especially on head and neck cancer, where the burden is very high in the French West Indies. So yeah, so that was my little commentary on this, just to tie in with what was said this morning during our keynote address. Okay, so do we have any? Okay, so we still have a little time left. I'll just I mean, I have my own questions. I mean, Boris has spoken about this work a lot. Um, so what do you think would explain? I mean, some of the because these results are going were consistently inverse associations. Uh, how does this compare? How does this inform the scientific debates? These inverse results. Because how do you just speak to the comparability of other studies?
So in terms of comparability to other studies, we found that so certain conditions like in our studies, such as, for example, diabetes, GERD, we found associations with other studies where other studies as well saw this negative association between head and neck cancer and these diseases, especially studies that were done in the US, specifically Michigan and Minnesota. We saw two studies there. And then for when it comes to other conditions, such as like especially the chronic conditions, chronic inflammatory conditions like asthma, for example, the leading hypothesis, even though like a lot of some studies found positive associations, other studies found inverse associations, and there's mixed hypothesis supporting both sides of the coin that was seen. And so I think one of like as I mentioned earlier, one of the reasons why we went in was because when you look at the literature, there's not a consensus, there's not a general consensus as to what direction most of these associations are going towards. Sorry. So we try to do this as well in the Caribbean context where it has not been done before. But I'll say that yeah, like literature out of the Caribbean, research that has been done out of the Caribbean is inconclusive as well. There's a lot of these mechanisms, there's a lot of the biological mechanisms that can still not yet be explained when it comes to some of these conditions, and they're linked to head and neck cancer.
Okay, so wonderful, Boris. Thank you very much. And of course, great work. I mean, proud of you as well.